An anal fissure is a tear or ulcer in the lining of the anal canal which causes pain on defecation. Anal fissures most often occur in the posterior midline of the anal canal. Anal fissures can be classified as acute, if present for less than 6 weeks; chronic, if present for 6 weeks or longer; primary, if there is no clear underlying cause; secondary, if there is a clear underlying cause. Prognosis. Primary anal fissures. Around half of all acute primary anal fissures resolve within 6 to 8 weeks of conservative treatment, dietary/lifestyle measures, and pain relief. Spontaneous resolution may occur within 2 weeks, often before medical attention is sought. Approximately 40% of people who present with an acute anal fissure progress to chronic anal fissure. Chronic primary anal fissures are more resistant to conservative measures, and often more intensive secondary care treatments are needed. Recurrence of anal fissure is common, especially if dietary and lifestyle measures are not adhered to. Secondary anal fissures. Prognosis of a secondary anal fissure is dependent on the prognosis of the underlying cause. Causes. Primary anal fissures do not have a clear underlying cause. Acute anal fissure can occur due to trauma from passing hard or loose stools, but many cases are not associated with constipation or diarrhea. Other etiological theories suggest that development of anal fissure may be associated with a persistent increase in internal anal sphincter tone, which leads to reduction in arterial blood flow, local ischemia, increased risk of tearing, and poor healing of the resulting fissure. Local deficiency in nitric oxide synthase, which is needed for production of nitric oxide, the main mediator of internal anal sphincter relaxation. Secondary anal fissures can present with atypical features and are associated with an underlying condition. For example, constipation, passage of hard stool tears the anal mucosa. Conditions which can cause ulceration of the anal mucosa such as inflammatory bowel disease, sexually transmitted infections such as HIV, syphilis, and herpes simplex, colorectal cancer, dermatological conditions such as psoriasis and pruritus ani, bacterial, fungal, or viral skin infections, anal trauma, for example from previous anal surgery or anal sex, adverse drug effects, for example opioid analgesics, nicorandil, and chemotherapy, pregnancy and childbirth due to pressure on the perineum. Fissures related to childbirth are most commonly located in the anterior midline. Diagnosis. Take a history. Ask about symptoms. Anal pain always occurs with passing a stool. Pain is severe and sharp and often followed by deep burning pain that persists for several hours. Bleeding may occur with defecation. When present, it is usually seen as a small quantity of bright red blood on the stool or toilet paper. A tearing sensation on passing stool may also be described. In children, anal fissure typically presents with pain and/or crying during defecation and rectal bleeding. Ask about the duration of symptoms. Acute anal fissures are present for less than 6 weeks. Chronic anal fissures are present for 6 weeks or longer. Ask about features of an underlying cause including dietary and bowel habits, for example constipation, diarrhea, or any recent changes. Children often have constipation. Pain on defecation may lead to stool retention and harder, bulkier stools, which cause further damage to the anal mucosa when passed. Previous anorectal trauma, including anal surgery and obstetric history. Associated symptoms, such as abdominal pain or weight loss. Family history of possible underlying causes, such as colorectal cancer or inflammatory bowel disease. Examine the person. Assess the anal fissure. Ask the person to lie comfortably in a lateral position and gently part the buttocks. Anal spasm and pain may prevent full visualization of the fissure. Acute anal fissures are typically superficial with well-demarcated edges. Chronic anal fissures are wider and deeper with muscle fibers visible in the base. The edges are often swollen, and a skin tag may be visible at the end of the fissure. Primary anal fissures are usually singular and occur in the posterior midline of the anus, although a few cases may be seen in the anterior midline, especially in women. Secondary anal fissures may have an irregular outline, be multiple, or occur laterally. These require further investigation to identify the underlying cause. Exclude a thrombosed hemorrhoid, which may present similarly. If a secondary anal fissure is suspected, assess for features of an underlying cause, such as constipation, colorectal cancer, gastrointestinal tract, lower cancers, a sexually transmitted infection, such as HIV or syphilis, inflammatory bowel disease. Consider the possibility of sexual abuse if a child has an anal fissure, and possible causes, such as constipation or inflammatory bowel disease, have been excluded. Digital rectal examination is not recommended in primary care to diagnose anal fissure. Consider referral for examination under anesthesia if the diagnosis is unclear or if spasm and pain make diagnosis difficult. Be aware that anal fissure is less common in older adults. Consider alternative diagnoses. Differential diagnosis. Anal pain with or without bright red rectal bleeding may also occur with thrombosed hemorrhoids. Other causes of anal pain with or without bleeding include inflammatory bowel disease, sarcoidosis, infection, for example, tuberculosis, HIV, or syphilis, malignancy, for example, anal carcinoma or lymphoma, perianal abscess. Management of a person with anal fissure in primary care. Consider the need for referral. Refer using a suspected cancer pathway referral for an appointment within 2 weeks. If rectal cancer is suspected, refer to an appropriate specialist with urgency dependent on clinical judgment. If another serious underlying cause, such as inflammatory bowel disease or a sexually transmitted infection, such as HIV infection, is suspected, for example, if fissure looks atypical on examination, consider referring to a general or colorectal surgeon if anal fissure occurs in an elderly person. For all people with anal fissure, ensure stools are soft and easy to pass. If the person is not constipated, advise adequate dietary fiber intake by eating a balanced diet containing whole grains, fruits, and vegetables. This should be done gradually to minimize flatulence and bloating. Also advise that adequate fluid intake is particularly important with an increased fiber diet to maintain soft, well-lubricated stools and to prevent intestinal obstruction. Discuss the importance of correct anal hygiene, especially in children. The anal region should be kept clean and dry to aid healing and avoid complications of anal fissure, such as infection or abscess. Advise against stool withholding and undue straining during bowel movements, both of which can worsen anal fissure. Manage pain. Offer simple analgesia, paracetamol, or ibuprofen if there is prolonged burning pain following defecation. Avoid opioid analgesics as they can cause constipation and exacerbate symptoms. Advise that sitting in a shallow, warm bath several times a day, if possible, particularly after a bowel movement, may help relieve pain. For an adult with extreme pain on defecation, consider prescribing a short course, a few days, of a topical anesthetic, lidocaine 5% ointment, for use before passing a stool. Advise the person to apply 1 to 2 milliliters when required. For an adult with a primary anal fissure who has had symptoms for 1 week or more without improvement. In addition to the lifestyle measures described above, consider prescribing rectal glyceryl trinitrate, GTN, 0.4% ointment, provided there are no contraindications, to aid healing. Advise the person to apply twice a day for 6 to 8 weeks. Around 25% of people experience headache as a side effect, which may affect compliance. GTN ointment should be avoided in children and during pregnancy and breastfeeding. For people with secondary anal fissure for whom referral is not indicated, manage the underlying cause where possible. Give follow-up advice. For a primary anal fissure in a child, advise the parents/carers to return if the fissure is unhealed after 2 weeks, or earlier if the child is in a lot of pain. In an adult, review if the fissure is unhealed after 6 to 8 weeks, or earlier if needed, for example, if the person develops intolerable adverse effects from rectal GTN ointment. Advise all people that they should continue with the dietary and lifestyle measures when the fissure has healed to reduce the risk of recurrence. For a secondary anal fissure, follow-up arrangements will depend on the underlying cause.